Good morning, everyone. I'm Dinesha Siddhasinghe, Secretary of the Ceylon College of Physicians, and it's my pleasure to welcome all of you to the Young Physician Forum and the College Lecture of the Ceylon College of Physicians. So this is the last session prior to the annual academic sessions of the Ceylon College of Physicians, which is scheduled from 22nd to 24th of September this year. And we'll be starting with the Young Physician Forum, which is a platform for the senior registrars to showcase their presentation skills and to win the prestigious award, E.M. Vijayarama Award, at the annual academic sessions of the Ceylon College of Physicians. And I will warmly welcome our two judges, Professor S.D. Jayaratne and Dr. Nandana Dikkumara, for judging the session today. Without further ado, let me introduce our first speaker, Dr. Udari Samasiri, Senior Registrar in Neurology, Institute of Neurology, National Hospital of Sri Lanka. And Dr. Udari is going to talk to us on cerebral venous sinus thrombosis. And over to you, Udari.
Good morning to everyone. I'm Dr. Udari Samarasiri. I'm a Senior Registrar working in Institute of Neurology, National Hospital of Sri Lanka. First of all, I would like to thank the Ceylon College of Physicians for giving me the opportunity of speaking in this prestigious forum. So the topic for today is cerebral venous thrombosis, the multifaceted intruder, putting a lot of physicians and trainees in dilemma when it comes to diagnosis and management. So I'd like to open my presentation with the quote from Sir William Osler, the father of modern medicine. The value of experience is not in seeing much, but in seeing wisely. So we will go through a few cases which will give us a lot of information regarding a glimpse of the cerebral venous sinus thrombosis clinical picture. So the first case is Mrs. F, a 23-year-old mother in her second pregnancy, postpartum day 6, presented with acute headache of 5 hours duration. So on examination, her GCS was 14 out of 15, and vital parameters were stable. And finally, there were no papilledema. The left upper limb, there was a pronator drip with the power of +4/5. So this is for CT. I would like you all to focus on it. So what can you notice? There is a hypodensity in the right anterior frontal region with some hemorrhagic lesions. I will expand the pathological area for you all. So this is the presentation at the medical casualty. Actually, this is a real case. So this patient was thought to have a lobar ICH and was given tranexamic acid by the medical casualty team. But unfortunately, patient deteriorates the following day. So we will see why. That is the first case. And the next case is Mrs. J, as a doctor, it's a 35-year-old who presents with right hand weakness, which progressed over 1 day. And on further questioning, her colleagues have noticed changes in personality over the 2 weeks. There was clumsiness in the higher cognitive. So in history, there is a recent upper respiratory tract infection 1 month ago, and there were many contacts of COVID-19 infection. In examination, the patient's GCS was 14 out of 15, and there was on and off disorientation. The vital parameters were stable, and there was right upper limb weakness with a power of 4/5. And fundi, there were no papilledema. And this is a CT. From the first glance, it looks quite quiescent, but when you carefully analyze it, you can see there is hypodensity in the left thalamic internal anterior limb of the intercapsule and coded head area. And In contrast, we did a MRI study and which showed this. There was extensive thrombosis involving the sagittal sinus as well as the deep veins. So that is the second case. And this is third case. This is Mrs. C, a 40-year-old mother of 3, who presented with right side upper limb and lower limb weakness over 3 hours. And her husband has noted her to have few jerky movements on the same side. And there was a history of headache over 1 week preceding this event. On examination, the GCS of 15, vitals were stable, and there was right side upper limb, lower limb power weakness with a power of 3/5, and fundi were normal. And this patient actually came to my casualty, the neurology casualty, questioning for whether she is suitable for thrombolysis. And in the initial CT, however, there was just a hyperdensity over the left frontal lobe area with no hemorrhages. And this is the repeat CT done 6 hours later, which showed some hemorrhagic lesion. So those are 3 cases. With that in mind, I will go into the presentation for today, and this will be my outline. So initially talk about what is CVT, and then epidemiology, pathogenesis, and when to suspect the clinical presentation, investigations, and management. So what is cerebral venous sinus thrombosis? It can be defined as complete or partial occlusion of cerebral venous sinuses or smaller feeding cortical veins, which is called as cortical vein thrombosis. So this has a variable presentation, and therefore it is frequently missed and diagnosed incorrectly. But if treated appropriately, generally it has a favorable outcome, thus the importance of detecting it early and accurately. And the mortality is around 10%. So the epidemiology, usually annual incidence is around 0.4 to 2% per million population. However, in the recent past, with this COVID-19 pandemic, we see a global rise in the incidence. And that's one of the reasons why I chose this topic for this distinguished forum. So a female to male ratio is seen around 3:1, and females are more predominantly because of the use of oral contraceptives and pregnancy puerperium, which are known risk factors for thrombosis. And the median age is 37 years, and it is seen in the younger population. When it comes to the elderly, usually it is associated with malignancies. So around 8% are actually older than 65 years. Compared to males, females have a younger age of onset, around 34 years, versus in males, it is around 42 years. So this is from a study done at Oxford. So this shows the increased incidence with the COVID-19 infection. You can see it's almost about 80 times more than the previous, like in the general versus the general population. In the patients with COVID-19 infection, the CVT incidence is more. And even with the vaccination, you can see there is a rise in the incidence. So this is the trends. So compared to 2019 pre-pandemic world, there is about twice the rise in the mortality as well in this CVT population. Okay, so with that in mind, I'll go to the pathogenesis. So basically, the changes in venous stasis, vessel wall abnormalities, and hypocoagulability, which is the virtuous triad, causes thrombosis. And this thrombosis leads to venous obstruction, either partial or complete. And because of that, there is increase in the venous pressure because of the back pressure, and that leads to reduced capillary perfusion at tissue level. And also, because there is stasis, there is increased blood volume locally, causing increased intracranial hypertension. So initial compensation is there because of the pliability of the veins compared to arteries. There will be a compensation, and there will be recruitment of collateral veins, So in a chronic state, sometimes it can go unnoticed for months and sometimes even years. So once this compensation fails and there is further increase of pressure, there can be development of vasogenic edema, and there can be rupture of blood vessels causing bleeding. And also, because of the reduced perfusion, can cause ischemia and infarcts, which we call as venous infarcts. Right. So the risk factors I'll categorize according to the virtual stride. So hypercoagulable states like genetic thrombophilias, and acquired prothrombotic conditions like pregnancy, puerperium, nephrotic syndrome, anticoagulated syndrome, and also hematological disorders like polycythemia, thrombocytosis, leukemia, and infection like sinusitis and meningitis, intracranial infections, and also COVID-19 is a common cause nowadays. And the inflammatory disorders like SLE, sarcoidosis, and inflammatory bowel disease, and other vasculitis disease can be caused, and also malignancy. And drugs like oral contraceptives, chemotherapeutic agents like asparaginase, steroids are also known causes. And other things like vessel wall injuries, like head trauma, and also like interventional procedures like jugular catheterization and endovascular interventions can cause this. And we commonly see in the hospital setup following cranial surgeries, the occurrence of cerebral venous thrombosis. And the other cause is cerebral stages. That is mainly because of venous anomalies like dural AV fistulae, AV malformations, and other venous anomalies. And also following lumbar puncture, they have noticed because of the reduction in CSF pressure, there is dilation of the venous sinuses, and which leads to venous stasis. And there are reported cases which that has led to CVT. So a bit more about the risk factors, I would like you to focus on the first column actually. So majority, this is an international study done throughout the world, including Europe, Japan, and America. So, and that has shown about 50% of the cases are related to the use of oral contraceptive pills. And puerperium and pregnancy are also one of the leading risk factors, followed by the rest. Right. So I'd like to focus a bit about anatomy because that is important to understand the clinical presentation as well as the radiological appearance. So if we recap the anatomy a bit, I'd like to focus you to focus on this diagram on the right-hand side. So in yellow color, there is the dura mater, and within that you can see the venous sinuses, and a bit below that there is this continuous black line, which is the arachnoid mater, and beneath that there is the red line, which is the pia. So between the pia and the arachnoid subarachnoid space, and that is where the cortical veins run. So that ultimately drains to the venous sinuses. And apart from that, so the cortical veins can be divided into superficial cortical veins and deep cortical veins. And apart from that, there are emissary veins, which are basically anastomoses between the extracranial veins and the intracranial veins. And also there are diploic veins which drain the bone marrow. So it is important to understand this distribution because we can interpret the radiology easily after that. So this is a bit of a crowded slide, but I would like you to focus on this part. So the venous sinuses, mainly there is the sagittal sinus, and also there's the superior sagittal and the inferior sagittal. And that connects to the straight sinus, which drain at the confluence of the veins into the two transverse sinuses. And that continues as the sigmoid sinus, which is leading to the jugular vein. And anteriorly, there is this two cavernous sinuses, which are connected to the lateral from the superior and the inferior petrosal sinuses. So that is for the sinuses. And in purple color, you can see the deep cortical veins. Basically, there are basal veins which drain the thalami and the internal gray matter, that is the basal ganglia and also the internal capsule. So there are few of basal veins and which drain into two internal cerebral veins, which drain into the great cerebral vein of Galen, which finally drains straight sinuses, the sinus right here. Right. So then superficial cortical veins are there. So actually, there are like superficial cerebral veins which drain the superficial cerebral surface into the superior sagittal sinus, and then there are inferior cerebral veins, and then there is the superficial middle cerebral vein which runs in the sylvian fissure, and that drains to the superior sagittal sinus through this vein of Trollet and inferiorly to a vein of Lebbe to the transverse and sagittal sinus. So why are we bothered about this? Because the occlusion of these cortical veins and sinuses will lead to different clinical pictures. So in order to understand that, it is important to understand the anatomy. The clinical presentation, as I mentioned in my topic, is multifaceted. So that depends on, firstly, the venous territory involved and also the onset. So if the progression is acute and there is no time for compensation, so the manifest clinical severity will be more. In chronic onset, the insidious onset, there will be more time for compensatory mechanism building up, so the signs will be subtle. And also the degree of collateralization and also the tissue injury will all be important when it comes to the clinical presentation. So majority of patients with CVT have headache as a prominent feature, around 90%. And in about 40% there are seizures, and 20% present as a stroke. And encephalopathic presentation with reduced GCS is seen in around 14%, and about 15% of them will mainly present like an isolated headache. Sometimes even they can mimic a migraine. And about 13% will present purely with visual loss because of the persistent raise in the intracranial pressure. Right. This again is a bit of a crowded slide, but we will go through it slowly. This is to understand the clinical presentations based on the venous territory. So if you follow my last point, so in the superior sagittal sinus is one of the common sinuses which is involved with the CVT. So when that is involved, can cause isolated intracranial hypertension because of the obstruction of the arachnoid cannulations and obstruction to the CSF drainage. And also it can cause focal neurological signs like aphasia, homonymous anopias, and hemisensory loss, hemiparesis, like that. And also sometimes the frontal lobe involvement, they can come with psychiatric symptoms, isolated, but it is rare. So this will be the appearance in a CT or MRI, where there is edema and like parenchymal involvement on the either side of the superior sagittal sinus. And the next common sinus to be involved is the transverse sinus. So, and in that case, there can be like posterior cranial fossa involvement. So you can have cranial nerve palsies and also cerebellar signs, right? And because it drains this vein of Lebbe, which is, if you can remember the anatomy, it is overlying the temporal lobe. So it is draining the Wernicke's area. So if it is on the dominant side, it can cause like isolated aphasia. Right. And then you have other sinus, like sigmoid sinus, which can present like pain in the mastoid area, and again with lower cranial nerve palsies. And then you have the deep venous system, which I mentioned earlier, like the two internal cerebral veins and the vein of Galen. So that will, if those are obstructed, they will cause bilateral thalamic lesions, like depicted in this diagram. So that can cause like mental state disturbances. The patient can present with diffuse encephalopathy, coma states, likewise. And The cavernous sinus can be involved, so that will cause upper cranial nerve palsy, headache, and you usually know this presentation well. And then there are cortical veins. So cortical veins can present obstruction and present with focal neurological symptoms according to the lesion. And the thing with the cortical veins, they are not very pliable as with the sinuses. So they will manifest early, and the severity of the symptoms will be more. And they tend to rupture early, so they can produce ICH and also sometimes even subarachnoid hemorrhages because of the cerebral venous sinus thrombosis. Right. So a little about the headache syndrome. So the key in this is suspicion. So when to suspect CVT in a patient with headache. So always think if the patient has got risk factors. If the patient is a younger female and who has used oral contraceptives or pregnancy or puerperium and malignancy likewise. If a patient with risk factors come with headache, always think of CVT. And again, a patient who comes with headache and which is of different characteristics to the previous primary headache, think of CVT, a change in the character. So always you have to inquire about the characteristics of the headache, whether it's similar to the previous headache syndrome the patient had, or it's a different presentation. Usually the CVT headache is a continuous headache. And check for signs of increased intracranial pressure. So always make it a habit to check the fundus in a patient who presents with headache. So in the presence of papilledema, always you have to think of CVT as one of the possibilities. And other thing, as I mentioned previously, the focal neurological signs, altered consciousness, and the presence of seizures alongside with the headache make you more suspicious of whether this is a CVT. And then the stroke syndrome. So CVT is accountable for about 0.5 to 1% of the stroke admissions. It's a minor group, but the treatment is totally different. So you have to be able to identify it early and accurately. Otherwise, you can mismanage the patient, as in the first case I presented you at the very beginning. So when to suspect CVT or a arterial ischemic stroke? One thing is the patient will have more headache, and it will be more than acute. It may be a subacute onset, but they can actually come with acute presentations also. And sometimes they can come even with thunderclap headaches associated. So, and presence of seizures. And other thing in imaging that it does not fit into a single arterial territory. So another thing is they have a more a prominent hemorrhagic component and cortical edema. Right. So coming into the investigations, so the key in the diagnosis will be neuroimaging. So there are direct signs, which is make you wonder with the CVT, and there are indirect signs. So I'll go through one by one. So direct signs, one thing is the presence of the thrombus itself. So the first thing you will be accessible is to this non-contrast CT. So in that you can see one sign is this dense cord sign and dense vein sign and dense triangle sign. So they are all the visible thrombosed vein in different cross sections. So dense cord sign is actually the transverse sinus, which is usually in the same axial plane. And dense vein sign is when there is thrombosis of the cortical vein. And the dense triangle is you are seeing the cross section of the superior sagittal sinus, which is thrombosed. But again, there are pitfalls. So one thing is these bony artifacts may obscure this finding. And sometimes it can be confused with the subarachnoid hemorrhage or underlying subdural hematoma. And also it can be caused by a high hematocrit, because most of the time blood is denser than the brain parenchyma. So if the patient has polycythemia or dehydration, sometimes the normal blood in the venous sinus may look like this dense cord sign or the dense triangle sign. And the other thing is Sometimes if the patient has got cerebral edema due to some other reason, then the parenchyma will be hypotense. So comparatively, the blood in the normal venous sinus will show up as hypertense. So that will cause false positive signs. Right. Then with the contrast imaging, you can see the empty delta sign, which is observed in 25 to 75% of the cases, like here. So that is, again, because the thrombus is not getting contrast enhanced, the surrounding blood is contrast enhanced, you are seeing it like a empty delta sign. Again, there are pitfalls. So one thing is in the hyperacute stage, if the patient comes very early, where the thrombus is not well formed and it is very soft and the contrast material seeps into it, so it can be missed. And the other thing is in the very chronic stage where it is organized, then again it can cause enhancement of the clot, where you will miss it. And again, another thing is this, in the bottom picture, you can see there is a thrombus in the superior sagittal sinus, but the same picture in a different contrast window, it has disappeared. So sometimes the certain window levels where when you observe it in the console, you can miss it if you don't carefully follow up. Right. Then the other thing is pseudo-empty delta sign. So what is this? Sometimes in this topmost picture, you can see there is confluence, like this is the confluence of vein, and this is the superior sagittal sinus, which is draining to bilateral transverse sinus. And you can see that the transverse sinuses are originating a little bit higher up. So because of this high bifurcation, sometimes in the axial cuts, it can cause like show up like a pseudo-empty delta sign. And other things like epidural collections and also fenestrations and septations within the dural sinuses can lead to this sign. And these arachnoid granulations in the sagittal sinus as well as the transverse sinus can mimic thrombi. So there are a lot of radiological pitfalls. So the key thing is mainly we have to interpret this with high clinical suspicion and always correlate clinically. Right.
Dr. Samsiri, let me disturb you a minute. We are almost finished. We have finished the 30 minutes. We can have another 5 minutes time for you to finish your talk.
Okay, sorry. Okay, I'll rush through then the rest of the slides. So we can actually age the thrombus based on the MRI findings. So I will not go into details about and the other thing is the parenchymal changes, like due to venous sinus thrombosis, will be important in the identification of these cases because like as I mentioned, there are a lot of pitfalls in identifying thrombus. So basically, the presence of the cerebral edema that occurs in the cortico-subcortical location and not in the arterial distribution. And majority of the cases have hemorrhages, which are like flaky, multinodular, and subcortical. So those will be pointing towards the diagnosis of CVT. And regarding a venography a little bit, so CT venogram is highly sensitive and specific. This is based on data from direct head-to-head trials with the DSA. So that is quite useful when there's a resource poor setup. But if it's available, the MR venography is the best. And with the MRI, because the parenchymal changes, as I mentioned, the venous vasogenic edema and also the infarctions are well seen there. So there is less chance of missing out. And DSA players usually is, although it's the gold standard, it is risky and invasive, so often unnecessary. So it's useful when the above is inconclusive and you have underlying suspicion of underlying AB malformations and other venous anomalies. So management I would like to summarize is basically the anticoagulation. So low molecular weight heparin versus unfractionated heparin, the trials have found more benefit with low molecular weight heparin. And it has to be followed with oral anticoagulation, usually warfarin. And quality for this direct, the evidence for this direct oral anticoagulation is limited yet, but in the future it might change. There's a trial, the RESPECT CVT has shown like non-inferiority over warfarin with dabigatran. And the duration of therapy for a provoked DVT with transient risk factors is around 3 to 6 months. But before stopping, we will always repeat the imaging and decide on the duration of therapy. So it is case by case based because there is no trials or any evidence for this duration. And a single unprovoked CVT will continue treatment for 6 to 12 months, and recurrent CVTs, or maybe if the patient has persistent thrombotic condition, lifelong warfarin. Endovascular therapy, basically, there is no benefit unless the patient is having very poor prognosis, progressive disease despite the medical management. We will think of this, but there's like the morbidity with the procedure is very high. And other thing I wanted to emphasize was the reduction in intracranial hypertension is important. So, and sometimes even there's no like a SOL effect or no big bleeds, sometimes the patient may have idiopathic intracranial hypertension like picture, which might lead to progressive like increased intracranial pressure, which might finally the patient will lose the vision. So you have to follow up the patient's visual acuity, and sometimes they will need acetazolamide treatment. And if the patient has seizures only, there is a place for antiepileptics. There is no place for empirical antiepileptics. Right. So the mortality is around 10%, and patient will 15% will be dependent, but 75% will have a favorable outcome if treated appropriately. The risk factors for poor outcome are male gender, old age, encephalopathic presentations, large bleeds, and deep vein involvement, and causes like infection and malignancy. Because of the recurrence risk, it's around 72%, we are continuing oral anticoagulation. So what not to do? So do not base your treatment on solely on a non-contrast CT brain, because that can lead to misdiagnosis, mismanagement. So always you need the urgent CT venogram or CT MR, MRB to diagnose. And there's no place for steroids unless the patient has the inflammatory pathology. And there's no place for antifibrinolytics. It is contraindicated, like in the first case. So even for the ICH management, there is no recommendation to use tranexamic acid nowadays. So if there is worsening clinical condition, always think back whether this is something else, and also reconsider other possibilities like dural AV fistulae or AV malformations, which will need further embolization in addition to oral anticoagulation therapy. So the take-home messages are clinical suspicion is the key, and you will have to always be skeptic about the radiological reports, always correlate clinically, don't treat the report, and start treatment as early as possible. And patient education is a must, because this needs compliance from the patient side for long-term anticoagulation, and always follow up the vision. So that's all. These are my references, and thank you very much for listening.
Thank you, Dr. Udari Samasiri, for that informative talk on cerebral venous sinus thrombosis. In the interest of time, I can allow one question from the judges, if there is any. Professor Jayaratne or Dr. Nandana Dikkumara, do you have any questions for Dr. Samasiri?
Can I ask one question, Dinesha?
Yes.
Yeah, he said, just a simple question. When you diagnose venous thrombosis, how long, initially, what is the anticoagulant use? Is it the unfractionated heparin or low molecular weight heparin? And the second part of the question is, how long do you continue anticoagulation?
Yeah, initially we use a low molecular weight heparin because that has shown more benefit over unfractionated heparin as for the recanalization and also the clinical outcome wise. And for the risk wise, the bleeding is more or less the same. If the patient has got underlying severe renal impairment, or higher risk of worsening bleeding, other bleeding manifestations, then we might consider unfractionated heparin. The duration will be like, we will be starting oral anticoagulation coagulants at the same time. So once the INR is in the therapeutic range, we will be stopping the like parenteral anticoagulants, and the oral anticoagulants has to be continued, like as I mentioned, for a unprovoked CVT with transient risk factors is around 3 to 6 months. And if it is a provoked CVT, unprovoked CVT, it will be 6 to 12 months. And if the patient is found to have some other underlying thrombophilic condition or it's a recurrent CVT, then it's lifelong oral anticoagulant.
Right. Thank you. Thank you. That's all.
Thank you.
Okay, thank you. Oh, yes, you can go ahead.
Can I ask one question? Can I ask one question? I'm Nandan.
Yes,
Dr. Somsit, now this is a bit of extension of this thing. Now we have heard of most of the patients with this COVID vaccination, AstraZeneca was causing this thing. Do you have any data on or any evidence from Sri Lanka or other countries?
Actually, sir, Sri Lanka, the epidemiology unit is currently conducting a survey. So we have provided the data, but the analysis, the breakdown of results is not available yet. Worldwide data has shown actually there is increased incidence of CVT associated with AstraZeneca over Pfizer Moderna vaccines. And they have basically the vaccine-induced thrombocytopenic purpura is associated with AstraZeneca. So they have thought that might be the reason why it has caused more CVT cases over other vaccines.
Okay, thank you. It's a very interesting topic for discussion.
Okay,
But however,
thanks.
However, we'll have to move to the next talk. So let me hand over the certificate from the Ceylon College of Physicians to Dr. Udari Samasiri. And thank you very much for joining with us today. Okay, let's